Hi there, lovely person. You are seeing this video because most likely you might be interested in joining our DBT4FND group. And I began making this video because I realized that much of the time when we had an appointment together, my time was spent just reviewing these slides, and I had less time to get to know each one of you. And I would really thought it would be more beneficial for you to watch this, and then we'd have more time together when we do meet, and I give you the orientation when we talk about the group. So this is just a service to you to be more efficient in our time together and to have more chance to get to know each other on a personal level. But these are the nuts and bolts of joining a DBT class. I'm first going to orient you to the philosophy, how the logistics about how it runs, and then the guidelines, and then some of the day-to-day details that are required if you do decide to join. So, without further ado, I will first start off with what DBT is. So, DBT was developed and invented by Marcia Linehan. She does have a trademark on this, and she was a suicidologist in the late 80s, and she was trying to develop a treatment for what was thought to be a population of persons that were beyond hope. These were the chronically suicidal, often labeled with borderline personality disorder. And even into the 90s, when I was trained, it was really thought that there were no treatments that could help these people, and that they were just, we had to accept that they would be in the emergency room in and out most of their lives. But Marcia was a pioneer. She noticed that regular CBT did not work with this population. And so she decided to add some of Eastern philosophy, such as mindfulness and acceptance strategies, which many of which she learned because she had been trained both in CBT, but was a Zen practitioner, also a devout Catholic. And it ends up that from her memoir a couple of years ago, she revealed that she was actually institutionalized in late adulthood into her early 20s. And she was chronically suicidal. So she knows it from the consumer end. So she put all of her knowledge together to create this very robust and comprehensive treatment that, lo and behold, with rigorous scientific testing and randomized controlled trials and replications, showed that beyond a shadow of a doubt, this actually worked to decrease suffering and suicidal behaviors in this population. So after that, people got really excited about such an effective treatment and decided to try it on different populations. And now it's not just a treatment for people with borderline and suicidal behaviors, but it has been applied to all the major mental illnesses and has been found to be effective in almost all of them. And including, we did a small trial. It was not a randomized control trial, but we did a small trial for FND, and it showed some signal of efficacy. But it is now considered a transdiagnostic treatment. It's the backbone of the intensive mental and behavioral health programs across the country and internationally. Almost every program, including forensic settings, really rely on the principles and guidelines and the jargon and culture of DBT. So we're not doing anything radical. We're doing kind of the standard of care for intensive behavioral health. And what you'll notice, though, what's unique about ours is that we are applying it and modifying it for people with FND. And as far as I know, we're the only group doing this. And so that's what's unique about this. So, and you'll hear the term, what does dialectic mean? Well, woven throughout the skills training, the theme of duality, and that life is full of opposites that we're trying to balance and synthesize. And unfortunately, our frontal lobe and our executive functioning has really been developed to kind of classify things and kind of yes and no and black and white. And sometimes we get too rigid in our thinking. And so the dialectical behavior therapy really targets cognitive flexibility, being able to synthesize opposites. This comes from um, probably Marsha Linehan's background in Zen Buddhism that talks about the duality of nature. And so, with developing this more flexible style and thinking, this translates in a downward stream down to emotion regulation and helps us regulate our emotions more. So, when we're thinking more flexibly, we're more emotionally regulated, and then we're more behaviorally flexible and adaptive and can do things that are effective. And so, it is now, like I said, DBT is sort of the Starbucks of mental health. So every latte that you get at Starbucks is going to be the same latte you get at another Starbucks, even if it's 5 states away. So that same thing goes for DBT. Each practitioner has to go through rigorous certification and training, and it's standardized, and you know that you're getting the right dose and the right strategy, and so it is considered cognitive behavior therapy. It's considered a third wave form, so a kind of new and improved 3.0 CBT, and it's based on this biosocial model for all diagnoses, that we all have behaviors or symptoms that are maladaptive. And they come about as a result of probably a combination of both nature and nurture. So the nature part, the biological part, we think of that we're probably born with a certain sensitivity, temperament, biology, genotype, although this also, our biology can change with the environment, but some things are more fixed than others. And we also live in an environment that can be less conducive or more conducive to that biology. So when you have environments, though, that are not a good fit for our biology, this is called invalidating environment, and this I'll talk more about it, but it causes emotional and nervous system dysregulation. We'll call this emotion regulation. And it's that dysregulation that actually is responsible for creating symptoms. And depending on your biological sensitivity, you're probably going to express that differently. So some people might get depressed or have addiction. Another person might have FND and motor symptoms. And even medical problems can come about or be exacerbated in this model. But what's common for most human beings and their maladaptive behaviors is that there's some type of dysregulation coming on. So DBT is about addressing both biological sensitivity and invalidating environments. So invalidating environments can come from the personal relationships we're in, from our family systems, from implicit biases in our culture, in our government, in healthcare systems, on a global level. You can have all sorts of invalidating environments. So let's say your biology, you need 10 hours of sleep, but the job that you work out says, oh, you should only sleep 7.5 hours. That can be invalidating and dysregulating. You could be in a family in which everyone is sporty and you're the only academic brainy person, and you're devalued for that because you can't play basketball as well as the rest of the family. And that can be dysregulating. We can invalidate our own selves by the way our self-talk. So there's many levels of invalidation. So we'll be talking more about that concept throughout. And again, this slide is just to tell you that there's been numerous studies, and if you want to dive even deeper into the philosophy of DBT and the science, you can go to this website, the linehaninstitute.org, and look up the research data. It's a living document that's updated daily with all the research that's being done. So What I like to say is that this is actually brain surgery, even though it's a kind of psychosocial and behavioral intervention. When you do this, you are changing your biology. And this was one of the first therapies to really document changes in the brain after a year of the therapy. So, after going through 2 courses of the skills modules, uh, patients with suicidal behaviors had changes in their amygdala, and these were correlated with their difficulties in emotion regulation skill. And why this might be important to FND is that the amygdala activation, the problems with habituation, are present and are one of the abnormalities that are found when there are herd studies of people with FND. So we know it's probably one of the targets that we need to work on for most people. And so this treatment has really shown on a biological level to change and help regulate and normalize that amygdala. And we also will be giving you measurement-based care. And so you'll notice that every few weeks, sometimes months, you'll get this difficulty in emotion regulation scale. And we don't want you to poo-poo it and think, oh gosh, not another survey. This survey is a proxy for your amygdala. It is an indirect measure of what's going on in your brain. So we take it quite seriously, and we hope that you do too. And so it'll be a good measure about how well the treatment's working for you. The other part of DBT is that it was inspired after Marsha Linehan read the book called Don't Shoot the Dog by Karen Pryor, the world's leading expert in animal training. And it really infused this protocol as well to use radical behaviorism, which is based on classical and operant conditioning. So because this is radical behaviorism, anything is up for grabs as a behavior and can be shaped. So because we're very plastic in ability to be shaped, because that's how we survived as a species. That's why we've done so well, is because we can change our behavior and adapt to all sorts of environments, because we have this kind of software running that allows us automatically, without thinking, to change behaviors, often involuntary behaviors. So a thought is a behavior, an emotion can be a behavior, digesting your food, a medical symptom, migraines can be a behavior, hiccups can be a behavior, moving your arm voluntarily is a behavior. So everything is up for grabs for behavior and is influenced by these principles. So DBT first talks about classical conditioning as something that you can harness and use to modify your behaviors and get some control over certain behaviors that you may want to change, either increase or decrease. Most of us have things that we need to decrease, and we're assuming if you come into this group, you're wanting to decrease some of your FND behaviors. So first you have to identify them and know what they are, but after you do that, you can identify what might be making you vulnerable. So there's long-term vulnerabilities and there's short-term vulnerabilities. So long-term vulnerabilities might be that you might have a genetic predisposition. Some people, these types of somatic symptoms run in the family. There may be adverse childhood events or trauma that happened in childhood. We know that affects almost all behaviors and makes you more likely for all sorts of things. So we do know that childhood adversity is correlated and makes people vulnerable or can be a risk. If you've had another family member with a serious neurological illness, you might be at risk. So there's all sorts of long-term vulnerabilities you might identify. Sometimes having a major medical illness or event can make you vulnerable. Often, for example, people with seizure disorder and epilepsy are more likely to develop non-epileptic seizures, probably because they kind of have well-oiled behavioral circuit in place. But there's also short-term vulnerabilities, such as not sleeping well, or maybe having a certain type of food, or a type of stressful situation for that week, and financial stress. So there's both short-term and long-term. So when you use the DBT skills and learn them, you'll be applying them to your vulnerabilities and using them to decrease your vulnerabilities. But then, so vulnerability to me is like the magic enzyme of a chemical reaction. But there's also like molecules that just kind of get the chemical reaction going, and we call these triggers. So often, most people with FND initially don't know what their triggers are. They're happening beyond awareness. But if you're lucky enough to have identified and be aware of what the triggers are, there's very idiosyncratic. They may be a narrow hallway, or a type of voice tone, or a color, or flashing lights. It can be anything. But once the train leaves the track, it often after the trigger, within a few minutes, or less than a minute, or even a microsecond, you might notice that the symptoms start. So when you get those events that happen that almost invariably start the symptoms, you've most likely got a trigger. And so DBT will help identify those triggers and track them. And so there's two things you can do with triggers. You can avoid triggers, which is usually in life pretty hard to avoid something completely forever, or you can desensitize to triggers. And you desensitize by usually the help of a therapist or some support, and you gradually expose yourself to the thing that you've been avoiding, or is triggering over and over and over, just like an allergy shot, until you're not being triggered anymore. And when you avoid triggers, you often can get sensitized to them. So, for example, if I'm treating somebody who is triggered by small hallways to have their knees buckle, they invariably have avoided narrow hallways, as is logical. But unfortunately, that makes it, every time they do encounter a narrow hallway, it makes it more likely that they're going to have their knees buckle, because they've been sensitized. So it often takes a lot of intention, a lot of work, and discomfort to desensitize. So everything that happens before a behavior shows up is classical conditioning. So you work with that. But also, what can shape a behavior is what happens after the behavior, and we call this operant conditioning. So if a behavior is rewarded after it shows up, the brain keeps track. It keeps the score. It says, wow, that was adaptive. Maybe we should do that again. And this is all happening without your awareness. It's at the implicit reptilian brain level. So, for example, if you've been working all day and out of the blue, you have an episode of your FND symptoms, and they cause you to have to kind of take a break and sit down, your reptilian brain just got rewarded, because it got to rest, and it got to preserve energy. And reptiles love to preserve energy and just sit on a rock. Even if you have 100 things to do and you're really happy about doing them, the reptilian brain wants you to preserve energy, and it's been there for eons. And so the way out of that would be to actually sequence the reward before the behavior. So it's not that you shouldn't rest, it's that you should, you start to see that pattern, and you start to notice, like, oh, okay, I need to rest a few times during the day, so that you're satiated, is what we call it. And that reward is not equivalent, or isn't associated with the symptom, like the FND symptom. This also can occur with other people in our environment. Often other people in our environment are rewarding behaviors without knowing it, and without our awareness either. So, for example, I gave my 3-year-old daughter FND once for 2 weeks. She had broken her leg and she had her cast removed after the bone healed. And she came home, and it was a week and a half, 2 weeks later, and she was still not walking on her leg. And I got quite concerned, so I brought her back to the orthopedist, and he says, "Oh, don't worry, I see this all the time. I think you're just paying too much attention to it." I said, "What? I I was doing nothing." And she didn't even speak hardly, so how could we have communicated that? And so he x-rayed her leg, reassured me it was not broken. We went home, and in 3 hours, she was walking on her leg. So that really showed me that, wow, our arousal and attentional systems and emotional systems are so connected that if somebody else is even directing attention to something, that that is being picked up somewhere in the implicit brain of the other. And we're so attuned to each other that it can shape up behaviors without even us knowing it. So often people have super nice, nurturing families that have FND. But unfortunately, that nurturing can sometimes create this cycle. So we have to train families and clients to make sure that they educate their family to really not change their behaviors when symptoms show up, so this doesn't happen. And we do this in the group. Why I'm making a big deal about this is we have contingency management going on in the group. So if somebody has a symptom, we make sure they're safe, but we also try to act as if it's not going on. We try to have the symptom not interrupt the group and be group interfering. So you might be in the group and somebody has a non-epileptic seizure, falls to the ground, and I'll just keep doing the lecture. It's not because I'm being cruel or invalidating or think that the person is faking or anything. It's because we know that if I spent time attending to that person, it would make the symptoms worse and would be reinforcing, and we want to be learning how to keep going with our lives without letting the symptoms hijack us too much. So each person, each one of you, when you meet with me, we've come up with a contingency plan for safety. So we make sure that, I will respond if it's a safety issue. If you've never had a seizure and you have a seizure, I will definitely call 911. But for those of you who we have a safety plan that if you have a seizure, really the plan should be to not respond. We will not respond. And so just be prepared when you're in the group that might happen. It doesn't happen very often, but maybe once every 12 weeks, somebody has a symptom. And so if you're concerned about someone's safety, just chat us in the Zoom and try not to bring too much attention to it. The same thing is when you are having a bad day and no need to come to group and say, "Oh, I'm having a lot of symptoms today, please don't mind me." Because the minute you say, "Don't mind me," we're all going to be looking at you to see if you have symptoms. And so that can be not adaptive. So anyway, so we'll keep going here. So that's operant and classical conditioning. So the other components of DBT, there's actually 4. We're going to be delivering you only the group skills. And so that is so really this is a course. This isn't like traditional group therapy where you talk about process or talk about relationships in the group, although you may have a little of that and have a support group. But really, this is like a college class. We are going to be talking about skills, we're going to be modeling skills, and we're going to have you try on the skills. And so our main goal, myself and the co-leader, is to make sure nothing interferes with your learning and to optimize your learning of these skills. You, during your homework and with your individual therapist, will learn how to apply the skills as you need to the areas of your life where you need to do it. So myself and the co-leader, we're not going to know you intimately enough to know exactly when and where you should use the skills for you specifically, but that's why we require that you have a therapist so you can kind of bounce that more personalized, customized ideas out there. We're happy to support you as we can. But the reason also we have the group is just to be efficient. So your therapist doesn't have to actually go through teaching you the skills, and we kind of outsource and are trying to be as effective as possible. And then the other component of a DBT, comprehensive DBT, is therapy for the therapist. So therapists have a consultation team so they avoid burnout and make sure that they're adhering to the DBT principles. So we do have a consultation team. We meet weekly, and so we may talk about your case as a group. So we do a group think. Usually we're just dealing with group interfering behaviors on either participants, or sometimes our own behaviors are group interfering and we need to treat ourselves. So it's a very closed system that is making sure everyone is optimally functioning. And I think that's one of the wonderful things about this, is thinking about the things in a holistic way. So the skills you'll be learning are categorized into 4 themes. There's distress tolerance, emotion regulation, and interpersonal effectiveness. And the 4th is mindfulness. And because Marsha Linehan thinks that mindfulness, and I tend to agree with her, is probably the most important skill and required for all the other skills, mindfulness is sandwiched in between all the other skills. So you get it at least every 6 to 8 weeks, you'll get some mindfulness. So we run all of the skills through the academic year. So if you hang around from fall until spring, you'll get all of these at least once. We ask that you actually commit to at least one of the modules before giving up, or if you say you don't like it, like just try it out for the whole module. But we highly encourage that you do the whole year and you get all the modules. And if you want that amygdala change, and the evidence really seems to support that you need to do it twice. So it may take 2 years to get the full effect of DBT. And it is the skills are complex. It's very hard to become an expert at any of this. This is why I teach it twice a week, because I love it, because I'm always learning, and I never feel like an expert, and there's always room to grow. And so you can stay in the group as long as you can stay in the group for years. We have people that have stayed in the group 8 years. You can leave after 1 if you don't like it. And people will be joining and leaving at different times. We have open enrollment because we have the only DBT or the only FND program probably on the West Coast, and we want to provide it for as many people as quickly as possible. We've decided to do open enrollment, so people may come in the middle of a module. So just be aware of that. So the therapy itself is, not all of you are going to be doing comprehensive DBT, or therapists may not even know what DBT is, and that's okay too. There's plenty of evidence that just doing the groups, even if you don't have the other components, may be quite effective. So in traditional DBT, if you have all 4 components, we really talk about pre-commitment, and orientation is the first phase. That's what we're doing now. Then we ask for commitment. And for some people, they're struggling with suicide, not always with FND, but some people with FND struggle with that. So we ask you that you please don't commit suicide for at least the 2 years that you're in the group, and that you attend your group therapy, keep a diary card and a safety plan. And usually once you get the skills on board, the purpose of it is so often people need to do deeper work, like trauma-focused work, or grief, or something else has happened that they need to process. So, not everyone, but a large proportion of people have trauma or have some emotional event that has happened that they need to process. And if they didn't have the skills to do that because of emotion regulation issues, after getting on board with the skills, you'll have the tools to be able to do deeper psychotherapeutic work. And the idea with DBT is that we don't want people in the mental health system more than 2 years, that people can get hurt, they can get excessive care. And so that usually we try to limit the really comprehensive DBT to 2 years, although the group, we consider it kind of a support. And thus far, I've kind of had it an open-ended one you could stay in as long as you want. But for the real comprehensive DBT, usually people spend just 2 years, so at the most. And so we work on targeting behavior. So you'll be customizing this for yourself. You'll be your own animal trainer. We first work on decreasing maladaptive behaviors, the most maladaptive being if you have any suicidal behaviors or behaviors that could put your life or body at risk. The second would be any therapy interfering behaviors. So if you have any behaviors that are going to interfere with your learning or coming to group, we work on those. For some people with FND, it might be cognitive symptoms. If they just cannot read or write, that would be the first behavior to work on. Or if your symptoms are stopping you from getting on the Zoom call, that would definitely be a behavior. But if those are not present, then you move on to quality of life interfering behaviors, which most often are FND behaviors, are usually at the top of the list, or people wouldn't be doing the group. But sometimes FND maybe isn't as a major problem. There may be higher priority problems. But we suggest that you don't try to change more than one, maybe two at the most behaviors, because just like if you were training a puppy, you wouldn't teach the puppy 5 tricks. You teach the puppy 1 trick at a time, because you just can't learn. There's only so much learning that can happen. So we recommend that you be kind to yourself and work on the highest priority behavior in your life. And then once you've decreased everything you want to decrease, then you can also work on increasing quality of life enhancing behaviors, such as using DBT skills. For those who have suicide, we do request that your therapist and you have a safety plan filled out. Sorry, this slide isn't the greatest. You may not be able to see it. This is the one that we usually suggest, but you may have others. So if you've ever in your life had any suicidal thinking attempts or what we call parasuicidal behaviors, then we will request that your therapist and you make a plan, even though maybe you haven't had it for 5 to 10 years. But we just want to be prepared for the worst case. We expect the best, that you won't become suicidal, but if you did, we'd have a plan. And so we also ask that you fill out this diary card daily and send it to us weekly, which keeps track of your mindfulness, your DBT skills each day. So every time you learn a skill, then you're responsible for tracking it along with your symptoms. You can also use a diary card app. I'll talk to you more about that when we meet. And you'll do things like this behavior chain. So I'm going to stop the share. So I'm hoping this is all sitting with you okay. The next thing I'm going to move to is the calendar, because I think this kind of makes things make a little bit of sense about how the logistics of it works. So hopefully you can see this calendar. So you'll receive, once you decide to join, we'll send you a calendar. This is an old one. And it'll have the Zoom instructions in the Zoom room. I took it out of here, this one, but you'll get one with the correct one. And my phone number will also be on it, so you can call me at have me on speed dial, because I do my own scheduling, and if there's an emergency or something, it's best to call me direct, because if you try to go through the intake or the admin, it can take several days to reach me, even through my health. Okay, so each group, when you sign up, the group will open 10 minutes before the Zoom meeting. And so you can socialize. You don't have to come or socialize. But right at the hour when the group starts, we'll mute everyone, and we have 5 to 10 minutes of a mindfulness exercise that's guided. And then we talk about the mindfulness exercise so that everyone feels is optimally learning and able to learn at their best after doing mindfulness. If it's your first time, we'll have an introduction, and then we'll go on to the homework review, and then we will have a lecture. And the lecture material is this middle column, and it'll go over what handouts we'll be using for the lecture. We'll show them on the Zoom screen, so you don't have to have your material out, but you'll have a PDF that I send you that will correspond to these numbers. But also, if you buy the whole DBT spiral bound notebook that has all the handouts, these would be the corresponding handouts. So this is the lecture material, and then the last 10 to 15 minutes we assign homework, and then the group is finished. But we do leave the Zoom room open another half an hour so that you can socialize, or if you're needing help or tutoring, the co-leader is there to help you do that. And so each week it's the same format. It is mindfulness, housekeeping, homework review, lecture, and homework assignment. Wash and rinse and repeat over and over. So each one goes for approximately 12 to 15 weeks. So I hope that makes sense. The next thing I wanted to show you is actually the PDF that I'll be sending out. So let's see if I can find the PDF. Here we go. So I'll be sending all of this to you in the My Health after we have our orientation meeting. So you'll get the PDF of the entire curriculum material will be in one PDF, hopefully. And if you have any problems with that, we can brainstorm ways to help you do this. We used to have a binder, and you would have them in person, but now that we're remote, it seems easiest for us to just have you have your own PDFs online. And some people like to print them out too, if you're like me and you're kind of paper oriented. So if you see there's usually anywhere up to 144 pages, depending on which module you're on. And you'll see the handout, the H3 at the top here, but the numbers will be down below to help you that correspond to the calendar. So one thing I wanted to do is go over the guidelines. So participants who miss more than 4 sessions are just asked to not attend anymore and just take a break for at least 12 weeks. And you can come again if you're able to get more consistent in your commitment. Usually it just means somebody has some other priorities or a crisis going on. And so we just want you to attend enough for it to be consistent, and you're able to learn. And if you miss too much, it's just going to interfere with your learning and interfere with the group cohesion. But no one's ever been kicked out. You can always come back. And so when you join, we want you to support each other. And also privacy is a huge issue. We want you to keep the names of the other participants and information obtained during the sessions very confidential. Our compliance requires that you sign a video consent, that you acknowledge that responsibility. So it's not just your privacy on the line, but it's all the other people in the group. So you might not mind if, your uncle Arthur comes in the room and knows you're doing therapy, but the other people in the room may not, appreciate Uncle Arthur knowing their information. So we ask that you make sure that you're in a room where other people can't hear or people can't see. And if accidentally somebody did come in the room, you would immediately turn off your phone, turn off the video and turn off the sound. Sometimes we've had it happen just a couple of times over the past few years. And sometimes people will come in and they'll be in their background and you can't see them, but all of us can see them. And so I will port you into a waiting room. So if you find yourself in a waiting room, look behind you. There may be somebody there that you didn't know. And mistakes happen, but we try to make sure that they're minimal and don't cause any problems with privacy. We take it very seriously. We'd like you to come to group and session on time and stay till the end. The dialectic is, if you can't come on time or stay till the end, come to part of it. So if you have a doctor's appointment that conflicts, even if you can only come for 10 minutes, come. But we'd like you to have the intention to come for the whole time. Make every effort to practice the skills between sessions and commit to doing the homework. We'd like you to validate each other, avoid judging others, assume the best about each other, and to give helpful, non-critical feedback when asked, and that you're willing to accept help from a person if you ask for help. And then to call ahead of time if you're going to be late or miss a session. So either My Health message me or call me. I don't take texts, but you can always leave a voicemail. It's a confidential voice line. But only text me if it was a dire emergency and there was no other form of communication. Participants don't tempt each other to engage in problem behaviors. They come to, so for example, if you were under the influence of drugs and alcohol, and not too many people with FND struggle with drugs and alcohol, but there are some. We would like you to not use drugs and alcohol, of course, but if you did come, then act sober. The same thing for FND. We'd like you to come to the group not having FND symptoms, and we'd like you to do everything you know how or can do to prevent them. But life happens, and if you have FND symptoms, come anyway, and just try to have it not interfere with your learning as much as possible. And we also ask that you don't discuss in great detail your symptoms, because we're, as this says, we try not to have be triggers for other people, or because things can be contagious, especially triggers. So this goes for too much detail or too much body scanning. So we think that some part of the mechanism possibly of FND would be excessive rumination about bodily symptoms or body scanning. And so we ask that you talk about your symptoms in broad strokes, just like you talk about maybe your sandwich to somebody. You wouldn't go through each layer of the sandwich. You would just say, I had a sandwich for lunch. So we call that the sandwich rule. We'll be there if you kind of anyone gets off track to redirect them. The same thing goes for not triggering people to do excessive healthcare seeking. So if somebody, don't want anybody saying, oh, wow, that doesn't sound like FND. Maybe you should go to, a specialist to make sure that you're, don't have some rare syndrome, because often people are struggling with excessive utilization and healthcare that causes problems as well. So, just be careful of your content. There are also many people in the group do have PTSD, so just be mindful of triggers for people with PTSD. But we're there to kind of guide you. We ask that you do not form confidential relationships with or dual relationships with other people in the group while you're in the group. So, no starting a romantic or private relationship or becoming best friends with someone or a business partner. You're welcome to do that after the group. You can socialize, and many times people socialize between sessions or even during the summer. People meet up regularly, but we would like it to, if you do meet up with others, that you would include others who wanted to come, that you wouldn't exclude others. So, you could go to coffee with another member, but just make sure that, everyone would be invited, and you're not forming cliques or excluding anyone. We want it to be as egalitarian as possible. So, those are the guidelines, and then each group may come up with their own guidelines too that helps the functioning. And so you're allowed to eat and go to the bathroom, and feel free to do that. And even we can always revisit guidelines that are needed to make the group function. So we try to be a democracy. The other thing we'll ask that you do is actually, let's see this. So the only one thing that you have to do before the group starts is get me this video consent back. So you won't be allowed to come into the room unless this is signed. So make this a priority. So this will come in the My Health message. And so if you could just sign it. And you'll also be getting a diary card that has all the skills, and you can make copies of that. And we'd like you to send it through My Health to myself or your co-leader, so we can see how you're doing. We also have measurement-based care. We really would like you to participate in that, both because it helps us be able to customize the treatment and know how to help you best and make sure that you're getting better. And also because we do research from that, the measurement-based care, that might help other people as well. So we are continuously improving our program based on those results. You'll see the back of the diary card. We also have a emphasis on identifying emotions, since many people with FND have been shown to not be able to identify emotions and interoceptive sensations. Not everyone, but a large proportion. So we make a big deal to really focus on emotions, and then also to track your symptoms, whatever they are, and everyone's are different. Let me close this. We'd like you to allow us to talk with your individual provider. So we have this release of information. And for those of you that do struggle or have, even in the remote past, with suicidal behavior and thinking, we ask that your individual therapist, a primary therapist, fill this out. That acknowledges they agree with you being in this program, and that you have a safety plan, basically. So that's it. And I really look forward to meeting you, and hope I can answer all your questions. I know this probably didn't answer half of what you need to know, but at least we can focus on some things and be more efficient when we meet. Anyway, really look forward to having you in the group if you decide to join.